Hi, everybody. Thank you so much for joining us today. This is the CFAR Substance Use Program of Research seminar series. And also, we're uh, welcoming our T32 HIV fellows today during their seminar as well. So this is a joint event. Before we get started and introduce Dr. Solomon, I wanted to also share that. Oh, in the fall, we're planning some additional CFAR substance use program of research events. And one of those include doing a panel on pivoting and navigating alternate sources of funding and also alternate career paths outside of NIH. Just given the current climate, we're trying to organize a panel that can give folks more information about different pathways that folks have pursued. That was a great suggestion from one of the SUPR directors, Dr. Judy Han. We're going to invite former UCSF faculty who are currently working in like private industry and also colleagues who are working in the Department of Public Health as well as the California Public Health Department, just to provide different information about the landscape in those other areas. So stay tuned, and we'll share announcements when we have lined up those talks as well in the fall. But today we are very pleased to welcome our special guest, Dr. Sunil Suhas Solomon. Dr. Solomon is a professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. He is the chairman of the YR Gaitonde Medical Educational and Research Foundation in Chennai, India, and co-director of the Johns Hopkins Center for Infectious Diseases in India. Dr. Solomon is one of the first recipients of the Avenir Award, a director's award from the National Institutes of Drug Abuse in the United States, aimed at identifying individuals who propose high impact research and who show promise in being tomorrow's leaders in the field of drug abuse and HIV. And he is also the protocol chair of the ACTG MINMON groundbreaking global trial on the simplification of HCV treatment delivery, and currently serves as the protocol chair for the HIV Prevention Trials Network 103 Purpose 4 trial, which is the first trial of long-acting antiretrovirals for PrEP among people who inject drugs. So really incredible researcher, world-renowned, and we are so honored to have Dr. Solomon here to share his work with us. And also, he is our external advisory board member for our CFAR. So he is definitely very much part of our UCSF community as well. And so without further ado, please give Dr. Solomon a warm welcome.
Thank you, Milo. I'm guessing you can all hear me online as well, right? Should be good to go. Great, thanks. So over the next 45 minutes, I will sort of walk you through my career of the past 20, 25 years of how I've actually evolved my career. And I think there are pre-doctoral students here, doctoral students here. So there are different paths that would apply to different people in the audience. And hopefully it'll give you some ideas, and I'm happy to talk and more later as well. So these are my disclosures. I wanted to start. So I did my medical training in India, and I don't know how many of you have interacted with people in India. When we do medical school, we go straight out of high school, right? And it's 5.5 years of classes from 8 to 4, and you really don't get exposed to research much at all. And so when I came to do my master's in public health at Johns Hopkins in Baltimore, all you see are drug use and MSM, right? Because it's alive, vice, and max. That's your entire MPH curriculum is sort of built on that. So when I finished my master's in public health and I went back to India, and I was like, where are all the drug using populations in India? Like, why don't I see them? So I ended up speaking to a couple of people who were had worked with people who inject drugs in India, like in the 1980s. And I said, what, like, I'm in Chennai, Like I've seen your reports from Chennai, which says people who inject drugs exist. You've reported these data, but I don't see any of them in my clinic. Where are they? They said, oh, because you're in the wrong end of town. That you're in the north part of Chennai. All the people who are injecting drugs are in the south end of Chennai. And in India, the north end and south end is less than 10 miles. But in traffic and distances in India, it could be anywhere from an hour to 2 hours. Right. And so we ended up establishing a special site in the southern part of Chennai. So Chennai is like the bottom state in Tamil Nadu, and that's the state of Tamil Nadu, and Chennai is about right there. Right. So we're on the border. And so we started this whole thing from $200,000 supplements. Right? But this was also 2004. And we were able to establish a cohort of almost 1,200 people who inject drugs and follow them longitudinally for 3 years with $100,000. So that's how much money can be stretched when you go internationally outside of the US. And so those are things that you need to think about. Is our limited resources? Where do I go? Where's the best question to answer? So what we essentially identified was about a third had HIV, about 65% had antibodies to hepatitis C, and about 10% had chronic hepatitis B virus infection. And so we tried to refer these people for treatment. And because they were all part of the cohort, and when we were testing them as part of the cohort, the right thing to do was to refer them for treatment. But none of them were actually going for treatment. Right? Because I asked them, why aren't you going for treatment? They're like, oh, it's a different place, it's far away, I want treatment to come to me here. So what we ended up doing was we actually established a clinic on site at that same research site. And what I did was I spoke to multiple pharmaceutical companies in India, and I said, listen, we're running this clinic for people who inject drugs. Can you give me free supplies of medicines, whatever you have? Like I said, the only thing I didn't want was antiretroviral therapy, because that's something, if you start, you have to continue for the rest of their lives. Versus like if someone has like a bacterial infection, or someone has an upper respiratory infection, you could treat it in like 1 week or 10 days. And if they had like body pain, you could give them like paracetamol, they had cough. So you could treat like smaller infections. And so we got samples for all these different medications. And we went back to the people who inject drugs and I asked them, okay, when we have things ready, when do you want these clinics? They said, oh, we want them at a time when other people who inject drugs don't come. Right? Because they only wanted a clinic especially for people with HIV who are also injecting drugs. So that even within people, there was those different layers of stigma, right? There was the stigma associated with drug use. There was the stigma associated with being a drug user with HIV. So we ended up having these clinics every Saturday in the morning. And I used to go sit there and see about 20, 25 patients every Saturday. Initially, we were trying to be very strict about it and telling them, you can't smoke here, you can't inject here, and all these kinds of things. And we found that the more you were trying to tell them you can't do things, the less likely they were to actually come. So finally he said, okay, fine, you can smoke, but just don't smoke inside the clinic, go smoke outside. And so I never realized like there was no air conditioning, so all our windows are open. So by the end of the clinic, all of us were really happy because they were really smoking marijuana. Right? So it was a good experience every Saturday morning. The whole clinic was hot boxed by 12 p.m. and everyone was happy. The patients were happy. The doctors were happy. But that's how we actually started this program. And then we said, okay, now many of you are getting sick, so you need to get on antiretroviral therapy. So go to the ART center. I was like, I'll give you an outreach worker who'll take you to the ART center, which is literally like 15 minutes down the street. All you had to do was just go there. And this was 2004. Antiretroviral therapy was free in India at that point in time. So they just had to go there and pick up their medicine, but they didn't want to go. Right? And what we ended up seeing was extremely high levels of mortality. Right? And you can see that as the CD4s dropped lower and lower, mortality was as high as 34 per 100 person years, which means like 1 in 3 people was dead by the end of the year. Right? And when we compare this to what was happening in the alive cohort in Baltimore, we were 3 times higher than what mortality was in the alive cohort in 1980s, despite having free access to antiretroviral therapy in India. So we really wanted to understand why were people not going and picking up antiretroviral therapy, despite seeing all their friends and colleagues and peers dying. Right? Because you normally, like if you think about the early days of HIV, the fear of death is what actually got people to get on medications and stay on medications. But they were not going for simple reasons, right? When they went to an antiretroviral therapy center, it was like a very long wait time. Many of them were daily wage earners, which means they would go do manual labor, get paid for the day, and that would pay for their food, that would pay for their their drugs, for everything. And by going to these antiretroviral therapy centers, they were losing that day's wages. There's also some experiences like stigma that they're faced in these centers. Like I still remember one of my patients came back and he said, I'd gone there with my sister, and the doctor looked at my sister and said, your brother's a drug user, he's going to die. Why are you bringing him here and wasting everyone's time? Right. And so it's all these negative experiences that people face that prevent them from going to these places. But that was the same time there was all this emerging literature, especially around meth use, where you could give them incentives, contingency management to keep them clean, right? Like negative, every time you had a negative tox screen, you would get an incentive. And there was the similar things were being done with alcoholism and other conditions, but no one had really looked at it in people who inject drugs. Like, could we use incentives to improve engagement and care? So we actually saw one of the first trials at that point in time of contingency management among people who inject drugs in India to look at, could you give non-monetary incentives to get people engaged in care? And the way we did it was we didn't want to give them cash, because we said if we give them cash, they're probably going to go straight out and inject. So let's give them something else. So we decided to give them like soap, dal, rice, and things that people in their houses would need. And basically the way we came up with the value was to offset the opportunity cost of time. So if they were making like $2 a day, then we would give them $2 worth of goods. If they brought me back proof that they went to an antiretroviral therapy center, that they picked up their ART or they started their ART. This was again 2004, 2005. So this wasn't a test and treat era. So people would have to go, you had to monitor their CD4, CD4 had to drop to less than 350, then people would get an antiretroviral therapy. So that's the way we designed the study. And what we saw was there was almost a 3 times higher likelihood of people initiating antiretroviral therapy. But I think what was new to me was the mothers, the wives, the sisters of all these participants used to come to us and say, thank you, because we're getting so much food from this person. And it was almost an unintended consequence where we got the family engaged in the healthcare of the individual, because the family was benefiting every time this person went somewhere or the other. Right? But we never really saw any impact on viral suppression. So I'm still trying to figure out 20 years later what they were doing with the medication once they picked it up. They picked up all their medication on time. Like everything was picked up on time, especially in the people in the incentive arms. So every time they showed up there, they would pick up their medications, and there was like a clearly higher initiation was higher, but it was also the number of pill pickups timely was also much higher. But there was no different than viral suppression. So they were not taking their pills, but they were definitely picking them up. So, anyways, but then we were doing this in Chennai. And for those of you who know India, so Chennai was just on the bottom, and like India is like right in the middle of the 2 largest heroin producing regions in the world, right? So you have the Golden Triangle, which was like to the east of India, which is like Burma, Thailand, Vietnam, that whole area, which was historically the largest heroin producing region in the world, which had drug trafficking routes coming into India from Manipur, Nagaland, the northeast border. But then once the Taliban figured out that heroin is very attractive in terms of making money, the Golden Crescent, which is Afghanistan, Pakistan, Iran, became like the largest producer of heroin anywhere in the world. I think in 2016 or 17, they made like 8,200 metric tons of heroin, right? And almost all of it is like shipped out. Like nothing is consumed in country. And so we have all these drug trafficking routes coming into India from the northwest, right? So through Pakistan, through Punjab, coming into India. So India was like in this weird position where we were having drug trafficking routes coming from 2 different parts of the country. One, which is a lot more historical, the epidemic, where we've seen a lot of HIV, a lot of drug use since the 1970s and 80s in the Northeast. And in the North, which is a lot more recent and emerging, and we're still seeing outbreaks happening in different parts of the country. So India, like most other things, is home to the largest number of people who inject drugs, because we're home to the largest number of a lot of things. When you have 1.4 something billion people and you put 1%, that's like 100 million people. And so you end up being a home to a lot of things. And it's estimated we have about 850,000 active injectors across the country. So we said, okay, we were working in Chennai. How do we take this model and go across the country? And this was the same time people were talking about integrated services. This was 2009, 2010. We were talking about integrated services for HIV, where we would marry harm reduction services, with HIV testing services, with treatment services, but no such models where comprehensively existed. Like UNAIDS and UNODC had come out with those guidelines, the 9 essential services that you should try and package together. So we decided to do this trial in India. It was across the country, as you can see. And I think we were talking to someone earlier, I think Milo or someone, about writing grants. When you write grants, it's very easy to say, I want to do this across the country. But when you're implementing it, it becomes a lot harder when you realize the country is much bigger than what you think it is. And so we've said we're going to put up these 16 clinics across India and set up integrated care services for people who inject drugs and men who have sex with men. And so we essentially did a baseline assessment in 27 cities that were all over the country from the map to try and find 22 candidate cities to include in the trial. So we have 11 intervention cities and 11 control cities. And the way we collected these baseline specimens was all through respondent-driven sampling. And many of you are familiar with respondent-driven sampling. So the way it works is you find 2 people who are very connected, or you can find 3 or 4, but you start off with like a small number of people whom we call seeds. Right? And we give them 2 coupons. We say, go out, give it to any 2 people like you, have them come back in. And if they come back in, they can get included in the study, then you get a benefit, the participant gets compensated. So it's like a reciprocal benefit for people who get enrolled in the study. So they bring in 2 people, then you repeat the process with them. So they go back out, bring people. So in this way, the sample basically accrues itself. So this was in the city of Kanpur in central India, where there was no reports of people who inject drugs, but the government had heard anecdotal reports. Like there are people who inject drugs who exist in the city. Can you go and do something and see what's happening? So within 130 days, we had recruited 1,000 people who inject drugs. Our HIV prevalence was 31%, and only 3% had actually were aware of their HIV status. Hepatitis C antibody was 65%, and no one had even heard of what hepatitis C was, right? And so immediately this struck a different note. We're like, we went in there to do surveillance, but this looks like a really good way to find people, right? More like a case detection strategy, because it's sort of like a modified contact tracing. Like a contact tracing, you would stop if you didn't find a positive. But here, what this is saying is like, even if you don't find a positive, keep going, and you will eventually find more people, especially as you go further out. And what we actually found was the further out you go. So the principle of RDS is at a particular point of time, you hit equilibrium on like your primary outcome of interest, which in our case with HIV prevalence, which is the red line 3rd from below, right? So that sort of like plateaus off around 18% and stays constant. But when you look at that subset of people living with HIV, the top 2 lines, the further out we were going, the more we were likely to find people who were not engaged in care. Right? So it sort of makes sense, because when you're recruiting and finding people, you're most likely to find people who are engaged in services. But if you keep going further and further, once you've gotten to them, you're going to start tapping into these populations who were never engaged in services. Right? And so this is what we found. A similar group found this in Malawi, and this has been used even in the US now. It's called deep chain RDS. I don't know if any of you have heard of it. They've tried to use this to recruit MSM in the southern states, like especially Black MSM in the southern states, because they feel like the only way you can get to them is through their peer networks, and the further we go, the more likely we are to tap into these populations. So these are things we did in India, but now they're being used in the US and other parts of the world as well. And so it's one of these things where people are like, what happened? Why do we need to do research internationally? Because sometimes it's things that happen internationally can come back here, and things we do here can also go international. It's like a bi-directional knowledge exchange, I think. So we did that baseline assessment, and then we randomized them to either the integrated clusters or the usual care. And then we did the evaluation assessment in those 22 cities. So this wasn't a cohort we followed. We did snapshots of the community, right? So we did one snapshot of what things looked like when we started the trial, and another snapshot when we finished the trial. And it could be a completely different set of people in the baseline and post-assessment, because we were trying to measure the community level impact, not the individual level impact, right? And so we wanted to, did these clinics actually make a difference at the community level? The way we established these models, where we worked very closely with the state AIDS control societies, the National AIDS Control Program, and multiple community-based organizations that were working with PWID in these different cities. I'm focusing on the PWID, but I'm happy to talk about the MSM clinics we established as well. So we built it around harm reduction. right? So we worked within the opioid substitution therapy centers. It's called OST centers in India. So that was sort of like the middle of our model. And then we brought in HIV testing, we brought in condoms, we brought in referrals to ART, referrals for TB, individual counseling, general medical care. So we brought everything else around opioid substitution therapy because we figured that was the catch. And that's what would really draw people who inject drugs into a particular facility. So just to give you a sense of and we actually built a biometric system in each of these clinics that we established, but the biometric system did not record images. It was a unique hexadecimal code of your finger that would be recorded. And every time someone came back in using that code, we would know it's the same person who's coming back in or not. The actual images were not, and you would need the code, you would need the same scanner, and you would need the background to actually be able to connect people back to it. It was a very highly encrypted system that we had in place. And so in the cities of Punjab, in Punjab, in Amritsar and Ludhiana, especially Ludhiana, I think they were seeing about 685 clients a day, right? So they would see them within a 4-hour period where they would come in, put their fingerprint at the registration, the site coordinator's desk. They would go to the nurse's station. That fingerprint would trigger their dose and their name. So the nurse would get the dose, crush it, stick it in their mouth, watch them for like 15 seconds, send them out, the next person would be in. So it ended up being a very, very efficient way of delivering services. And the government has actually had us expand that to all the different opioid substitution therapy centers in Punjab and in Delhi right now. They're all running off biometric right now. Because the other beauty of having that biometric system is like if you have 8 different OST centers in a particular city, and the person could go to any of those 8 centers because they're all from a unique system, and you would know what your true retention is. But I think from a government perspective, what was more interesting was like how much duplicity was there. And because the way programs run is they all run off numbers, right? So like if you're a particular program and the government gives you like $10,000 to reach 100 people, gives another program $10,000 to reach 100 people, how do we know you're reaching 200 people and not the same 100 people, right? And so that's where this whole biometric system became very valuable to the government. But what do we do? So we basically found that we improved testing, but it was not statistically significant, right? Because we ended up seeing a lot more diversity between the sites at baseline when we began, because we thought the sites were going to be sort of similar, but it ended up being much, much more different. And if you've done cluster randomized trials, you'll know what the coefficient of variation and intra-cluster correlation numbers, they were extremely high. Right? And so we just did not have enough power. So people were like, oh, many of my co-investigators were like, it was not significant. And I was like, we can say it was not significant, or we can say we screened and provided services to over 60,000 people. And I was like, that's definitely pretty significant, at least to those 60,000 people who got those services. But I think what we really learned from this was a city like Delhi versus I'm trying to think of comparator cities. Like a city like Delhi would be something like a New York, and then like a really small city. They would both have just one clinic. And like, like in a small city, the one clinic may reach everybody, but in a big city like New York, one clinic may not be able to reach everybody. So because of the biometric, we were able to measure what the penetration of the clinic was in a particular community, like what proportion of PWID in a particular city had been to that clinic, right? And so that's those little triangles you see on the right. And so you can see like as you made more penetration, as in more people were able to reach the clinic, the effect was much higher, right? And so it basically said that maybe what we needed to do was like in the bigger cities, maybe 2 or 3 clinics, in the smaller cities, 1 clinic, and we would have seen our desired effect. But regardless, I think one of the good things of collaborating with the government right from the start was because they saw the value in this, they adopted this model. And now it's like in 71 cities, 71 clinics across the country. So it's been scaled up, it's running by itself. We no longer have to support them. We help them with their guides, their operational guidelines, their technical guidelines. And now the whole thing is being run by the government of India itself. But then, like I said, like we had 2 completely different epidemics, right? So when I went to the northeastern states of India and I asked them about HIV, it wasn't really a big issue because they've had HIV for a long time, since the 1990s, and they had figured out that harm reduction. They were all getting on treatment. But for them, hepatitis C was the biggest concern. A lot of their peers, a lot of their friends were dying of hepatitis C. because after being on antiretroviral therapy for a long time. Versus if I went to the northwest sides of India, like Punjab, and I asked them, what do you think about hepatitis C? They're like, what is hepatitis C? So you had like these two completely different countries within India itself. And so what we said was like, let's include hepatitis C antibody testing. So this was again 2015, right around the time sofosbuvir was in the market. So you had the first of the new generation of DAAs coming out. But what we saw with hepatitis C was because it was almost non-existent, we saw a very statistically significant improvement in the uptake and awareness of hepatitis C status. But at the same time, we saw absolutely no effect on SVR because treatment wasn't available anywhere at that point in time. And then when treatment did become available, there were all these like, you need to go get your genotype, you need to go get your HCV RNA, you need to go get your baseline tests, you need to get your week 4 test, your week 8. Like hepatitis C treatment pre-pan-genotypic regimens was very, very complicated, especially in the interferon era. And so we actually said, can we simplify this? So when sofosbuvir came out, there were 2 pan-genotypic regimens just based on sofosbuvir. One was a combination of sofosbuvir with pegylated interferons and ribavirin for 12 weeks. So it'd be like 1 injection once a week of interferons plus soft and riba every day for 12 weeks. Or you could do soft and riba for 24 weeks. So I'm talking about like before we had GP, before we had velpatasvir. So this was 2015, before we had Epclusa soft well in the market. So we did this trial in India where we took people and we randomized them to either get soft. And the only thing we did was like the interferon injection, we said had to be in person because they had to come in for the injection. So we said we would directly observe therapy of the interferon injection. What can go wrong? Like coming into a clinic once a week can't be that hard. Just as we said that, Chennai was flooded. Right? So we like the streets were covered with waters. The picture below is actually our airport. So we couldn't really get people anywhere. And so a couple of people ended up, we had to like figure out how to get them with interferon injections on time. But the other thing I will tell you is like all of us, I don't know how many of you have actually used interferons in practice or know people who have used interferons. People hate them. They have a lot of side effects. Right? The crazy thing about what happened in our trial was like people who got randomized to the all oral tablet arm were very disappointed that they were not getting any injections. Right? And the people who got the interferon injections and had adverse events, like they had a fever or they had like a headache or something like, oh, the medicine's working. I have a fever. Right? So it's just like people's perspectives on what will work in one community may not be the same thing that's going to work in a different community. Right? And like in India, we love our injections. And so it was just sad to see these people who were so disappointed that they were not getting interferon injections. And I didn't know what to tell them. But I think what was striking was we saw like almost 88%. If you look at the intent to treat, you're taking off the people who dropped out. None of them dropped out for adverse events. One of them, the family said they shouldn't stop taking. And I still remember one of them had like this vision that apparently asked him to stop taking treatment. And so if you looked at the as-treated analysis, it was like 100% SVR among people who were on the soft PEG-RIBA arm. And it's really showing, and for this, we never did any pre-treatment genotyping. We only did the CBCs and very minimal monitoring just because of the ribavirin adverse events, and we kept it going. But then we said, okay, why can we take what we did in India and take it across the world? And this is when velpatasvir had just come into the market. And so I worked with Mark Solkowski through the ACTG. So we started this protocol called MINMON, which is ACTG 5360. It was a phase 4 open label trial, multiple countries. We had Brazil, South Africa, Thailand, Uganda, and I think it was 31 sites in the US, including UCSF, if I'm not mistaken. It was a single arm trial, 400 participants. Everyone received 1 tablet once a day of Softwell. And the way we designed the approach was Softwell was pan-genotypic. So why do you need a pre-treatment genotype? And it was still a requirement at the time when we designed this trial, but we said, why do you really need it? Like, are you going to change your decision based on this? Probably not. The second thing we did was, at that point in time, people had to come back in every 28 days, go through insurance, get the next bottle of meds, go back. And if you're like a long-distance trucker or hepatitis C, or you're someone else, that may be an interruption for you. Plus, if you look at HIV and other conditions, we give them 6 months worth of medicines. Right? So I'm like, what happens if we give them 3 bottles? They're like, oh, it'll be super expensive. They're going to lose it. That was the argument we got from our science committees. They were like, "Oh, it's very expensive medications you're giving them. They're going to lose these medications, or they're going to go sell these medications. So we don't advise giving them 84 tablets at a time." So that's okay. We're going to give them 84 tablets and see what happens. And then we said, there's absolutely no reason for us to do any on-treatment monitoring. These drugs, like in the phase 3 trials, had a safety profile that was comparable to the placebo. You have your guidelines based on pegylated interferons and boceprevir, telaprevir, all the older generations, where you were bringing them back every 4 weeks. And there was actually something called response-guided therapy, where if people weren't responding, you would stop treatment to prevent exposing them to like interferons for a longer period. So that's why we used to have a lot of that on-treatment monitoring. So we said we want to get rid of all that. And then the last thing we were asked to do was, you can't give them so much medicines and never see them ever again. Like, you have to have some contact, because I just wanted to give them these tablets and say, go home, see you in 6 months. But they said, no, you have to have some contact with them. So we said, fine, we'll have 2 remote touch points. This was again 2015. Before remote touch points, I feel like today are like commonplace, right? Like, since COVID, it's become like normative. In 2015 and 16, when we were trying to explain to the sites, you can't bring them in. You can call them, you can text them, you can email them, you could WhatsApp them, but you can't bring them in. You can talk to them via WhatsApp. And they were like, but we don't understand. Right? Because it was just a different concept at that point in time to tell them, don't bring the participant in. Just figure out a way to communicate with the participant without having them come in. So we had 2 remote touch points. One was at week 4, just to be like, hey, I'm hoping you started your medicines, hope everything is going well. Then we had one more at week 22 to say, it's about time you come back in for your SPR assessment. So let's check if you've been cured. So come back in. So those are the 2 remote touch points we had. And we only used the PIB4, which is pretty much available in any primary healthcare center anywhere in the world. And so you really didn't need anything. So the most complicated test we needed in this was the hepatitis C RNA, because you need to confirm active infection before you can start people on treatment. But if you're working internationally, and even in the US now, I think the gene expert, they're looking at trying to getting that certified to use for HCV RNA, which will give you a result in like 45 minutes. And it's a cartridge. You don't need a specialized lab. Anyone could, like, with like 10th to 12th grade worth of education, you could train them to use the gene expert. And what we essentially found was like 379 out of the 399 achieved SPR. And despite like having like no requirements, we just said, forget everything, just give them the tablet, send them home, let's see what happens. It was like a 95% SPR, which was similar to what we saw in like phase 3 trials, where patients were asked to come in every 2 weeks with like several blood draws. And so this sort of has like changed the way we've been managing hepatitis C, not just in the US, but globally, right? Especially like in resource limited settings where you don't have access to genotyping and these other tests, is making it very simple to give people things. And I think this is one of the biggest lessons I've learned, is like especially in high resource settings, we tend to overcomplicate things because we have access to things. Versus when you go to a low research setting, you actually get to that point of like, what is the minimum number of things I need to get this done, right? And if we can bring some of that back here, I think a lot of our programs here will be a lot more efficient than they currently are. But the 2 limitations we had with this was we had very few active injectors. I think what 14 or 15 out of the 400 reported injection, and very few were very active. And it also showed that one size does not fit all, because especially for young people who were enrolled in the MINMON trial, we didn't see an extremely high SVR. Right? And so we wanted to work more on people who inject drugs, because that was the population I feel is always being left out of the agenda, whether it's HIV or hepatitis. But then at the same time, we also recognize that hepatitis C does not have as much money as HIV does. Right? And also people are fundamentally different. Right? You can't say like this intervention is going to work the same across multiple people. Because what randomized clinical trials do is at baseline, they traditionally say, all of you are equal, and I'm going to randomize you at 1:1:1 across these arms, assuming that each of you is going to have a similar likelihood of success, regardless of which arm you go into, right? But then you know that people are different. Like someone who's injecting 10 times a day, not on opioid substitution, and experiencing unstable housing, is going to have a poorer outcome than someone who is on opioid substitution therapy, older, married, and living at home. But traditional RCTs don't take that into account. So what we designed was called a precision randomized RCT. So I didn't design this. It was like a group of biostatisticians whom we worked with at Hopkins. And I think this is the first time I've actually used it in a trial. So what this does is that it takes your propensity for failure, right? So it takes your likelihood of failure given certain characteristics at baseline. So here we use like your recent injection drug use, your number of sexual partners, your age, your homelessness status, and that start out a score saying your probability of failure is X or Y or Z. And if that number was higher than 0.57, we said you were at high risk for failure. If it was lower, we said you're at low risk for failure. So what it essentially does is like it breaks your entire randomization into two different strata. So you have a strata which is at high risk for failure, then you have a strata which is at low risk for failure. So the strata that's at high risk for failure, you give them more of the high intensity intervention. Because in our heads, we believe that they are going to benefit more from that than someone who's at a low risk for failure. Instead of giving it as 1:1:1 equally, you're actually distributing it so that there is some benefit. But because the whole thing is randomized and because the whole thing is controlled, you could take it all back to a randomized clinical trial in the end and look at the average treatment effect. Right? So it was and this is something we've done for hepatitis C, but we're looking at, can we use this now for long-acting ART or long-acting PrEP? Because many people will do well on oral ART. Many people will do well on oral PrEP, right? And then long-acting ART, long-acting PrEP are a lot more expensive. So can we use these predictive algorithms to figure out who's going to benefit more and channel those patients in for those particular programs? So we had 3 different interventions: basic support, which is giving them medications, peer navigation. This happened in the middle of COVID, so it was not what we designed, but this is what we had to end up with because we wanted to actually do daily directly observed therapy. But then the OST program shifted, everything shifted during COVID. And then the PN plus DOT was like the basic support, but then at least once a week, the dose was monitored, and then they were dosed every 7 days. And so you would get 7 days of medicines. That was the group with the most intense therapy. And this is just to show you like these groups ended up being very different. If you look at the low risk and the high risk, so you can see in the high risk group, the proportion of hepatitis with HIV was almost 30%. Proportion experiencing homelessness was 26%. Daily injection was 89% versus 42%. So like your high risk group really was that group at high risk of treatment failure. 93% of them actually returned for their SVR. So this was a trial of 3,000 PWID, right? So we were able to bring back 93% for that SVR assessment, which I thought was probably the highlight of the trial because nothing else really worked. Our overall SVR was only 59%. For those of you who have been following hepatitis C trials, that's usually like 95, 85, 95, 100%, right? But then that dotted line in the middle, that's the overall. And you can see the low risk group is doing a little bit better. The high risk group is doing a lot worse. So I've been looking at a lot of literature and I found that this is probably the only trial where the median age is about 30 and about 60% of them are actively injecting. But if you look at those two groups separately, like active injectors or people under the age of 30, their viral suppression is always like in that 65 to 70% range. But when you look at it in a whole group where the majority is being controlled by the other populations, it gets pulled up. Right? And people who are injecting drugs on medications for opioid use disorders do really well. But then I think there were only like 33% in this cohort compared to like 65 or 80% in the other cohorts. So it's a lot more complicated. But I think the one thing that was striking was like that propensity score, right? So that was the likelihood of you failing therapy. And the score, the lowest likelihood was on the left, the highest likelihood was on the right. So if you just look at that orange bar, right, you can see it's much higher on the left and it starts dropping as it goes towards the right. So what that basically means is like, yes, we were able to predict failure, people who are at highest risk for failure pretty well, but our intervention didn't work. Like our intervention worked in the people at the lowest risk of failure, but as we went higher, we needed to do something more than what we were already doing to get them up to that higher level. So we're trying to figure out like, how do you actually apply this in like other diseases and other conditions, but also for hepatitis C as well. And what we did see was like an extremely high reinfection rate, right? So this is like in Delhi, if you see that the topmost line was like 80 per 100 person years. That means that you're curing people, and then before you get to like 1 year, 80 out of the 100 people you're curing are being reinfected with hepatitis C. So we do need to do something beyond just hepatitis C. And we also looked at the proportion of people at the end of treatment who were undetectable, but were detectable by SVR, which basically means that we're getting reinfected before we could even test for cure. So you finish treatment, you were cured, but before we could test you for whether you've been cured, you've already been reinfected. Right? And then there was about 315 people. So if you put them into that, our re-estimate for SVR will be closer to 69%, right? Which is one way of looking at it, but I think the bigger challenge is like, how do we actually prevent reinfections, right? And there's harm reduction, there's therapies, but then we are looking at like the newer formulation, the long-acting harm reduction products, like the long-acting buprenorphine, can that be used to reduce frequency of injection? But also just trying to take a more, obviously we don't have any vaccines at this point in time for hepatitis C, but that's again something that we should be looking at. There are long-acting formulations of hepatitis C treatment that are on the horizon. So we're wondering if that may have a role to play, if you can treat more people. Because reinfection is basically a function of like cure and susceptible, right? And your reservoir. So the more people we cure, you make more people susceptible without impacting that reservoir. So we really have to bring that reservoir of people who can transmit down to a level where the number of new infections is lower than the number of people being cured. And then you will start trying to bend that curve. I don't know if that made sense, but so that's sort of what we need to figure out is like how much faster or how many more people can we treat. So we're treating so many people at the time that you're actually going to end up at a point where you have fewer people being infected than people being cured. And when you treat small numbers, like in Delhi, for example, we treated 250 out of 8,000. Right? So essentially, you made like 250 more people vulnerable without treating the 7,750 people who could transmit it back to this 250. And so thinking about it from a bigger community perspective, like how do you scale up treatment? Where do you scale up treatment is something to think about. Now, while we were saying hepatitis C, HIV incidence continue to remain high. Like in Delhi, it was 18.5 per 100 person years from our cross-sectional surveys. And I was very interested in understanding, like, despite all these interventions we were doing, why was HIV incidence so high? So we established this longitudinal cohort in New Delhi to characterize the role of the different networks. And I'll walk you through what these networks are. So the egocentric network is probably the most simple network, which most of you know. It's like one person, you ask them, who do you inject with? I inject with ABC. That's your network. That's the egocentric network. The sociometric network goes one step further. It says, who do you inject with? I inject with ABC. Then you call ABC and ask them, who do you inject with? And they give you their names of people. So it's like your first degree, second degree, and third degree of connections, right? So that becomes your sociometric network. And then we have something else called a socio-spatial network, which has been done a few times, but I was very curious about the role of space or places where people inject on transmission of infectious diseases. So the square boxes are spaces, right? So some people may not have injected together with each other, but they are connected because they all went to a common venue for injection, right? So they may not know each other, but they were all injecting at that same place over a period of time. And then the last thing is the socio-spatial, which basically takes ties which are both individual or space. So it counts your steps. So if I'm connected to Milo through the nursing center, but we've never injected to each other, then we would be like 2 steps away, one to the school and then from the school to him, right? Versus that's the way we're counting spaces. So each step along that path is like your network distance. And the further you are, the less the effect that particular spot or that particular individual should have. So why this is important is because I will tell you as we go forward. So we recruited these networks of people who injected drugs. We started with indexes, so a little different from RDS because we asked them to recruit only their injecting partners. So they had to name their injection partners, give us something unique about them, and we'll give them coupons specific for those injection partners. They would bring them in. So it started with 10 indexes. We recruited about 2,512 people. The median number of coupons we handed out was 1. But about 75% of the coupons came back. So 1 coupon was handed out means the network size was about 2, right? Because you got your coupon from someone and you gave your coupon to someone else. So there's always 2 levels of connection on average between these different people. Baseline HIV prevalence was 37%, and 92% had detectable HIV RNA. And the same thing, the number of HCV antibody prevalence was about 65%, and about 80% had active HCV RNA. So this is what the overall network looked like. Each of these little circles is one individual. Obviously, the big black in the middle is like our first index. We found out later he was actually a drug dealer. And so that's why he had like so many connections across his whole network. And then when we looked at the infection, so if we didn't look at it through space, like if we didn't have location and where people were, then we wouldn't understand how the infection is distributed in that particular city. But you can see here for both HIV and for hepatitis C, there's like a big clustering of the infections, like right around the middle of the city. And these are all kernel density heat plots, just mapping the prevalence of HIV and hepatitis C by different parts of the city. Our HIV incidence was 21.3 per 100 person years. When we stopped the cohort before COVID, we've had even more seroconversions since then. And just to put this in perspective, if you're looking at all the big prevention trials, the red thing on the right is just the number of new infections in 1 year in Delhi. And this is like about 15,000 people over several years, right? And yet we don't really have any prevention products for people who inject drugs. So I think Milo mentioned it. So we are running Purpose 4, which is in the US. It's a phase 2 trial. We're trying to see whether people who inject drugs will benefit from long-acting lenacapavir. So this Purpose 1 was among heterosexual women in Africa. Purpose 2 was cisgender, men who have sex with men, transgender men, women, and non-binary. Purpose 3 is among cis women in the US, and Purpose 4 is among active injectors in the US. So if that trial pans out and works, it'll probably be the first first product to have an indication for PrEP among people who inject drugs. We're about halfway through the recruitment, so we'll see how that goes. And so with that, we also said, okay, why is there no, so remember that study I showed you in Chennai in 2006? So we tried to repeat the study in Delhi, and that's what our viral suppression looked like in this cohort. Like we could barely get to 10% viral suppression. Right? So it really explains like why we're seeing such a high incidence is because we have so much of HIV, no one's virologically suppressed. And so there are a lot of these. So we're currently also looking at trials of long-acting antiretroviral therapy, really modeling around what Monica and everyone has done in UCSF to see can we do that in India. Because we will have generic products in the market in India soon. So we could probably work with the generic products because it's going to be easier than trying to get all the pharmaceutical companies to buy in to do the trial. So these are just predictors, and I think what I want to focus on is the number of viremic partners, right? So I showed you how low the viral suppression was. So these are markers which sort of support the whole treatment is prevention among people who inject drugs. So the number of viremic injection partners is in your ego network. Per additional person you had who was viremic, your likelihood of being HIV infected was 31% higher, acquiring HIV. And the further you were, the network distance is like, so if I was viremic and there's like 2 people between me and Milo, then Milo's likelihood goes down by that much. The closer he is to me, the higher his risk of infection, right? So that's what the network distance means, which again makes sense. Like if you're injecting very close to someone who's infected, your likelihood of infection goes up. But as you go further and further away, your likelihood of HIV infection goes down. But I think what was really striking for us was like just one venue, that big purple spot accounted for like, well, if you were injecting in that spot, your likelihood of HIV acquisition was 4 times higher, regardless of anything else that you did. Just going to that one particular spot and injecting. And the further you were from that spot, your likelihood of infection went down. And just to show you what that looks like, so each of these purple dots is a spot in New Delhi. And this is how the network was built over time. The white are all the HIV negative or undetectable. The pink are all the ones with prevalent HIV, so the ones who could actually transmit HIV. And the reds are all the incident infections. So you can see like all these red incident infections started seem to be going in right in that big circle in the middle. So that was that one hotspot that we saw that was accounting for all the infection. And so what we essentially found was like, out of those 159 infections, 113 reported injecting in that one particular hotspot. So I wanted to see what was that hotspot. So I went down to the hotspot. It was basically just this blue abandoned shed, right? But then when you walked around the shed, you would just see like lines of people injecting. And most of them are probably sharing drugs. At any given point in time, there were about 300 people injecting at this particular spot. Any day, at least 1,000 people were cycling through the spot. So, and when I actually spoke to them and I asked them, like, there's an HIV testing center and a harm reduction center about 100 meters down the street. And I said, why not? Like, it's like right there. Why don't you go use harm reduction services? And their whole concern was like, I'm living on the street. I have no food. I have no shower. Why do I care about HIV? And so that really changed the way we did our HIV programming in India. So we started something called the Blue Shed model in honor of the Blue Shed. And this was actually done in partnership with Abbott Labs, because the guy who was the head of research at Abbott was with me. And I was like, can we turn this into a diagnostic facility? And then all the antiretroviral therapy, harm reduction supplies comes from the government. And we have a bunch of community-based organizations who bought in. So it really is a collaboration between industry, academia, CBOs, government, to try and see, can we actually make something happen? So we had all the diagnostic and medical services, but we built in the social support, we built in showers, we built in toilets. And so this is what the actual facility looks like. The actual Blue Shed was gone. That's what I actually wanted to turn into this, but this was like through COVID. So it was like 3 years and the Blue Shed was like demolished. And so we had all these medical services, but then we also put like showers, we put haircuts, we put food packets, right? So like once a week, people can come and get haircuts there. It's kind of impressive it's kind of hard to explain how much getting a haircut means to some people. Like we just take it for granted because we can go get one whenever we want. But when you're homeless and you have no access to a shower or no access to money, just getting a haircut makes you feel more human, right? And so it's like these simple things that we started doing. And then we started these services called eSeva, which is giving them like their ABA card, which is the Ayushman Bharat health scheme, which gives them health insurance so they can start going to government hospitals. So you would have to go to a particular facility to get that, but people were not going there. So we spoke to the government and brought that facility into the same Blue Shed complex. But the crazy thing is, like, we still see a lot of HIV here, right? And so it's about half of them are HIV infected, 76% have antibodies, about 8% have hepatitis B surface antigen. But the good thing, I guess, is like we've provided close to like 130,000 food packets so far to all these different people who are coming. About 800 people, 500 people come every day to pick up their food. And when they come for their food, and many of these people who are being diagnosed with HIV are being diagnosed for the first time, no one is coming here to get an HIV test. Right? They're all either coming here to have a shower or to pick up food or to get a haircut. And when they come for their food, we're like, hey, you're here for food, why don't you go get screened? Or you're waiting for someone to come on to go use the shower, why don't you go get screened? Right? So it's almost like you need to figure out what they want. Like I think we very often talk about person-centered care, but then we're still very HIV focused. Because as researchers or whatever it is, for us, our primary issue is always like, how do I answer my research question? It's never like, what do the communities want? Right? And so it's almost like flipping the narrative completely. I mean, like we can answer our questions when their needs are met. And so what are their basic necessities? Because for many of us, these basic necessities, I think we take for granted. Because most of us are sleeping on a bed at night. We are waking up at home. We do have coffees. We do have food. We don't really think about this the way they think about it. So for us, the biggest question is like, how do I get them an HIV test? And sometimes maybe the way to get them an HIV test is to give them a coffee. Right? So really figuring out what that is. And the only way we're going to get to that is actually talking to them. Right? So I would really encourage everyone to start talking to clients because especially since COVID, I think this happened where we're trying to do a lot of our research sitting in classrooms and over Zoom versus like actually going out into the field and talking to communities. But that, and again, it's not just with people who inject drugs. So we had a similar model for the trans community in India. We registered about 6,000 trans men and women across 3 clinics. And again, for them, it wasn't HIV services. It was gender affirming care. We're just having someone to talk to them. But we also, like in India, the trans community is actually held pretty high. And so they have all these different schemes. And so coming in there and giving them access to a computer where they could get access to those schemes made a huge difference to them. And laser hair removal and hair whitening were like the biggest demands. They all wanted to be fair. And it's sort of the opposite of what everyone wants in the US. Everyone wants a beautiful tan hair. In India, everyone wants to be fair. And so they wanted to come in and talk to the doctors about all these skin whitening creams they'd read about and whether they should use them. And it's the same thing we're doing. And we actually had to stop this because of the USAID termination as part of the executive orders. But fortunately, we have found corporate social responsibility funding within India. So we'll probably get this back up and running in the next week or so. And it's the same thing with adolescents. Right? So we were working with a lot of young people who inject drugs in the Northeast, but they were all like 18, 19, and they were testing positive. But I was like, why can't we get to them earlier? And so we went and spoke to the kids there. And we said, what do you need if we need to get you into a facility? You know what their biggest requirement was? Wi-Fi. All they wanted was Wi-Fi, access to Instagram Reels and YouTube Shorts. They said, if we can come there and sit and watch Instagram Reels and YouTube Shorts, we'll come. We're like, okay. So we gave them like Wi-Fi. So it's about 3,000 children have been registered. We've screened about 1,000 for HIV. We found about 35. So it's much lower than the adult injectors, but 35 out of 1,000 is still a lot of HIV in this particular population. So it's really trying to understand what the communities want. And I've done this multiple times, and we're actually trying to do this now in Baltimore. And we had to actually do it in India to show that this works, to try and make the case that let's start doing it in the US. Because there's a similar challenges we have in the US where everything is segregated and segmented. Like you go to different places for different things. So it's what time we think about how you actually bring all these different things together into one venue. Because it's not just about their HIV, it's about them. Right? And putting them before the HIV or putting them before the hepatitis C, that's the only way you're actually going to make a difference. A lot of people to thank, a lot of funding sources. The slides are recorded. If you really want to see them, you can go back and look at them. My battery is going to die, so I had to stop sharing slides soon, I guess. And I just want to end with this vision of a picture of the blue shed. I think when we went there, it was one of like hopelessness and despair, which seems to be where all of us are today with things that are happening. But there's two ways to deal with it, right? One is like we just sit and say, okay, this sucks. We have nothing. We can't do anything about it. Or we figure out solutions. Right? And I think all of us are creatively smart enough to figure out solutions. So we just can't let that get to us. Right? So we got to sort of, I think, compartmentalize. Whatever you hear in the morning goes out the door, then figure out for the rest of the day, how do I make things better? Because like we have to and we can. And I think it's something that collectively, it's no longer academic competition. Because earlier it was like, how many grants does Harvard have? How many grants does Hopkins have? How many grants does UCSF have? I think it's time all these different universities come together and figure out how do we solve these problems, because these are much bigger than each of us individually or as a university. So that's my message. Go out, figure out creative solutions, solve the world's problems. Thank you. I think she had a question. It's different in different parts of India. So, like in the northeastern states, should I repeat the question? Or can people online here repeat it? So the question was like, how did the harm reduction services work in the different settings across India? Was it happening in the community? Was there a lot of acceptability around it? So it was different in different parts of the country. So, like in Delhi and in Kanpur, where many of them were experiencing homelessness and living on the streets, it was much easier because they were looking for it. It was easier to go to the fields, go to the hotspots and distribute it. But in the northeastern states where they're all living at homes and where there's like a very religious presence, harm reduction wasn't big with the families. It was more of an abstinence. And many times what would happen is like many of our, especially the youth, would get rounded up and put in these abstinence camps where we wouldn't see them for like 2 weeks, 3 weeks, and then they would come back out. And I think it's a lot of, we're trying to work with the churches now and talk to, because it's not more it's more the churches than the communities, because the communities understand the benefits of harm reduction, why they need it, but it's trying to make the churches understand, especially because when people go in a detox and they come back, that's the highest risk of overdosing, right? So trying to get that message across to them and has been the biggest challenge. So the clinics that we established, all our doctors, staff, everyone was trained by us. We had client satisfaction forms where they could actually tell us problems they had with specific staff. And when they did, we actually brought it up with the staff. In the government settings, we've started doing a couple of training modules to teach them about taking history, not just for people who inject drugs, but even for the trans community or for MSM. I actually feel the trans community has it a lot worse in India than people who inject drugs, because they send them to the women line and send them to the male line. So the facilities that we run, we actually have a lot of client satisfaction surveys. That's sort of what we do. And we work with many of the CBOs in that particular city. So we have them give us feedback on the services we're running, especially with our staff, right? Because you want to make sure your staff are sensitive to their needs. So did any staff treat any of your people badly? Have you heard of anything like this? And so having a complaint box definitely helps in all these facilities. Now it's your turn. Well, we've gone up. We're at 20% suppression now. They are. I don't understand why, because our mortality in Delhi is still like 30 per 100 person years. So it's like a lot of death. They're seeing like their peers dying, but there's just so much volume, right? Like in Delhi, I think the number of people who inject, the estimate is 80,000 drug users just in Delhi. And so it's just like the size, the sheer, and a lot of turnover, because a lot of them are migrant workers who are coming to Delhi for work. So they come and they leave. They don't really have friends, right? They're like you're the people you're injecting with today. If you're not going to be that, that's why I think the location makes a big difference. Because if I'm injecting in a particular location with you today, and then I show up tomorrow and you're not there, it's not like I want to say, oh, she hasn't shown up, I'm not going to inject. You're going to find someone else who's there and inject with them. Right? And so it's like that rapid turnover. And I don't understand why it hasn't happened, but we've actually decentralized ART. We're providing ART from the blue shed. We're up to maybe 25-30% suppression, which one of my school leadership like, oh, you almost tripled the rate. I'm like, yeah, but it's 30. I was like, yes, it's like it is triple, but we're at 30. I want to be at like 80 or 90. That's where we want to be. But we are looking at long-acting ART specifically there, because I think one of the challenges many of them have said is because they sleep on the streets, they either lose their medicines or the medicines get stolen. And so they're not able to take their medicines every day. And we've offered them, like, why don't you keep them here? Then they're like, then we have to come there every day. And sometimes our jobs are in a different part of town and things like that. So we didn't. So the biometric that we used in our network to establish linkages where linkages weren't reported. So if you didn't report someone as your partner, but your biometric matched with someone else, we were establish those linkages. But what we have done is we have done phylogeographic analysis using sequences, and that has shown us a lot of mobility. We've only sequenced it from 4 cities: Amritsar, Delhi, Kanpur, and Imphal. And what it shows is like it starts off in Imphal, and then Imphal and Amritsar are the 2 entry points for hepatitis C. But then from there, it comes to Kanpur and Delhi is like an epicenter from where it goes to multiple places. So there is a publication on that, and I'm happy to share it with the person. We have two more questions here. No, I think it's a great question, and it's something we've struggled with. We've not looked at the caste system per se, but from majority of the people whom we end up getting in all these studies end up being from the lower classes. Right? But I think what we are trying to do is we're trying to come up with like a vocational skills building program. So you actually train them on because to your point, I think is very pertinent is because most of what we do, whether it's in the US, even in the US, like, I mean, what we do is like we get them on harm reduction services, we put them back in the same environment, right? Without giving them skills or an opportunity to change where they came from. So we are looking, well, everything has been like on the back burner over the past few months, but we're trying to figure out if we can find some funding to actually build vocational skills, whether it's like carpentry or whatever it is, but then place them in a job outside from where they are. And then see if that makes a change. Right? It could be like, it could even be like in the service industry, in hotels or in restaurants, but building a skill and giving them a different place to go to. That is something we are actively exploring. I don't know of too many studies that have done that, but I think a few have actually given money and looked at whether money itself can change people's behaviors. Non-conditional cash. So there's conditional cash where you do something and you make them like it's tied to a particular behavior. Like if your tox screen is negative, we'll give you this. If your ART is suppressed, we'll give you this. The non-conditional cash transfers are like, here's like $500 for this week. Go live your life. To look at that. And there's been like mixed reports on that, whether it works or it doesn't. But I think if we could tie it to a skill and place them in a place that addresses the environment that they're coming from, right? And really changing that exposure to begin with, that probably is the answer. There was one there, and we'll come back to it.
Ollie already bringing a lot of concern about the scale, and I'm going to get all the funding in this thing. I guess I'm wondering what people thought about that.
That's actually one of the aims of my trials to look at emergence and transmitted drug resistance. But so the tail, I don't know, it's very hard. Like it's a huge deal. People made a big deal about it, but the problem is like we haven't really seen too many people go into that tail. You know, like even in 083 and 084, everyone switched to the open label extension. So you didn't really experience that tail. And most of the breakthrough infections happened on treatment. And so like in a setting like in the US, I would be less concerned about the tail only because your incidence is much lower. But in a setting like India or South Africa, I would be very concerned about that tail and specifically looking at, is that going to result, not just the tail, even for long-acting ART, right? It's like you give them that injection of Cabanova and then you don't see them for 6 months. What have I done? Right? It's like the question no one knows the answer to because all the trials have been so pure and so clean in populations where we've had good access. I think Monica has that, 5359 is the other trial. But even in that, I think 5359 actually had a fair amount of resistance among the people who failed Cabanova. Right? So it's one of those, it's very different because you look at it from multiple perspectives, which is what I always struggle at. Because in the US, it's very easy, like, oh, yeah, they failed, oh, we'll switch them to PIs. But when you go outside of the US, if you go to Africa or Asia, the way PEPFAR programs run, you procure in bulk, right? So if you buy TLD, then 95% of your stock is TLD and you barely have any PIs left. So you kill TLD, then what are you going to do? right? It's like you're gonna have to switch your whole procurement process to find the PI regimen that you're going to use to treat. So that's the part where it gets tricky. In the US, I would be a little less concerned about it, but the PrEP part, the ART part, I would still be concerned about, because the challenge always is long-term suppression. Right? Like giving people 3 injections and getting them suppressed by month 6 to show like a huge difference, anyone can do it. Like you can give them money and they come back for the next 2 months. I will give you $100 per injection. People will come back. But are they going to come back for 24 months? That's where the bigger question is. And I don't think we've got the data in those populations because and again, it's like, I'm looking at all these trials that come out like, oh, we'll take people who are virologically suppressed and doing well on oral and give them something that's more expensive and show that they can still be suppressed. I'm like, yes, but what about the people who are not suppressed, who we need to get suppressed? But there are starting some trials now at unsuppressed populations. So I think long-term data is what we would need in those populations to see, are we able to maintain suppression? Because short-term suppression is definitely doable. Like I wouldn't doubt that it's going to, like giving people 3 injections over a 4-month period is not going to be hard. But will I be able to give them injections over 18-month or 24-month period becomes a lot more tricky. But yeah, so that will be my take on it. I think I'm a lot more worried about resistance with CAB in the non-US settings than in the US settings. So in India, we're not in Baltimore, we're actually seeing 25% of all the injectors are using amphetamines in Baltimore, which is the first time I've actually seen so much amphetamines in Baltimore. In India, we're seeing primarily opioids, but it's like a mix because you can pretty much buy anything over the counter except for morphine, I think. But pretty much everything else you can sort of buy over the counter. So we see like these random mixes like benzos and tramadol and all sorts of drugs and painkillers and antihistamines. Like it's like this random mix of drugs. We do see meth and ecstasy and cocaine in MSM who are engaging in chemsex. In that group, we're seeing a lot more. But then that's purely like stimulant use and no opioid use. We haven't seen that mix like you're seeing here with like speedball and goofball and things like that. Yeah. You took over. I'm kidding, Mira. It wasn't more of an ethical reason. It was like in our heads, we're like, this trial is going to work. And then we could just use this precision algorithm to dispense treatment, right? Because if it worked, then you would just do the algorithm. And if people were in low risk, we would just get them the low intervention people. Because it's like, it basically comes down to a money factor in the end, right? If I had unlimited money in the world, I would do the most intense intervention for everyone. But if you had to pick and choose, then it was not purely ethical. It was also a question of like, could we predict who's going to be at high risk for failure? Right? Because if you can predict, then you could actually just treat them. We did predict. We predicted, but then our intervention didn't work. So we're trying to figure out what next to do. Yeah. I think a lot of our contingency management stuff has been sort of replicated here, like with HPTN 065 and other trials that looked at monetary incentives to achieve different steps of the outcomes. The biometric has been replicated in Baltimore. They started doing biometric in Baltimore after we started in India because it's just easier to track people and provide services and things, especially for research settings. The other thing we're doing in India, which I didn't present here, is we're looking at there's a little bit happening in the US. It's like all these virtual testing, right? So like providing services to people on like Grindr, Blued, Tinder, because they're all in these virtual places who never actually come to physical. Well, they may be going, I don't know where they go, but you could actually, so we have these virtual outreach workers who go to Grindr, Tinder, and Planet Romeo, and they go and chat with them on the app and say, hey, I'm from this organization. I want to talk to you about HIV. Are you interested? And if they say yes, then the whole conversation moves to like WhatsApp. Right. And then that's where we see a lot of chemsex, we see a lot of group sex. And then we provide them with like HIV testing, we provide them with STI screening, we provide them with PrEP, we provide them with like ART if they're positive. But everything happens remotely without ever seeing them. And you guys are in San Francisco, the tech capital. Like I feel like you should have enough resources around you to try and figure out, can we actually do that in the, especially like I think in San Francisco, it'd be like worth trying because I'm guessing like there'll be a good sizable population online in some of these cities, like San Francisco, New York, and places like that. Yes.
I also found that I wonder if you think about it, like that, while we were in that done the treatment, maybe that's why it's so I wonder if that's very effective there for virus people that is there any potential for whether or not extend treatment or have to think about like that starting from the
Now I'm only smiling because I feel like you read one of our grants that went into the NIH. No, because we literally have a grant that's evaluating HCV PrEP. So for those populations, like could you keep them on an extended period of time? You can. You know, go to India to find that high incidence though, but no, it's like because like I think what you said makes complete sense, right? Like people were getting reinfected during that point, that time they were on treatment, but that treatment was curing them or preventing it or whatever it is. Because like honestly speaking, I think like 6 to 8 weeks of DA is good enough for most people, and the other 4 weeks is probably like preventing people from picking it up. The minute you stop it, and the next time they get exposed, they pick it up and it shows up. So we are actually actively, so we submitted something, it's going back in on May 7th, so we'll see what happens. To see whether we could, we said what we're essentially trying to evaluate is like people who achieve as end of treatment undetectable, randomize them, double-blind placebo control. They either get soft well for an extended period of time or they don't get soft well. And we want to see what reinfection is. Again, it's not to advocate soft well as PrEP, but it's more to advocate soft well as like prophylaxis or whatever for a particular period of time until we can get enough people treated that your reinfection rates are going to drop. So that's the whole idea. We're trying to see, I was trying to do this a long time ago. I was like, why aren't people doing HCV for PrEP? Like, you do it for HIV all the time. Yeah. It's the cost, yeah. But there is a fair amount of reinfection even in the US, especially like you look at the HERO study and the other studies among active injectors. Yes. They did it for a research study and they were all fine with it. They didn't have anybody who, they did the same thing. They walked them through it. They allowed them to play with the device and everything, showed them the back end, showed them there was no image stored and they were fine. Because even if the government gets it, they just get these random number of codes and they can't figure anything out with those codes. Yeah. And they trusted the outreach workers who were working with them. Because it's more about the outreach workers than the individual workers. At this point in time, no.